How are you?
Good evening. Welcome.
Hi, Bill.
Hello.
This is Stan.
Hey, Stan. Yes, I can see your name here.
Am I the first one on?
Oh, there's a lot now.
Oh, good.
I see familiar names. Hello, guys.
Hi,
Welcome.
it's Gail here.
Hi, Gail. We'll just wait for a couple of minutes for
Okay.
other people.
Do your sound off.
Unmute your speaker.
Mute your speaker to increase volume here, participant.
All the people that are signing in. There's me. Good to see you.
There you go.
Chris is my therapist.
Super. Bill, maybe if you want, you can go through your traditional kind of housekeeping stuff, and then we'll
Sure.
just do the icebreaker question at the end of that.
Sure. Okay, good evening, guys. So, welcome to our first Zoom workshop. We used to do this once a month in clinic, and then we get to see each and every one, familiar faces and new faces. But now, because of what's happening around us, we are now we are now interactive. So it's our first ever Zoom shoulder pain workshop. And welcome. And just a few housekeeping tips. Everyone, if you're about to if you have a question in mind and you wanted to ask Blair, I would suggest that you can use the chat box and then make sure that your chat box is in on default to panelists and attendees. So each and everyone can read or interact with your question. And then yeah. And then if you do have if you want to butt in or just you can also raise your hand here in the chat box, and I am watching and gonna read it out loud with to Blair. And when you're not talking, please mute your mic so that everyone will be, will just be focusing on Blair. There you go. So I think, Blair, it's time. You can start now.
Awesome. Well, welcome everybody. So my first interactive icebreaker question is we're going to test everybody to see if they can use their chat box tonight. So my burning question, has COVID-19 pandemic and social isolation changed your buying habits? So in the chat box, just say yes or no.
Changed our what habits?
Buying habits.
Buying?
Yes.
So there's a lot of yes.
Yeah. So that's a pretty given question for a lot of us. It's changed our world, and like already what we used to do in-house now we're going to do online for a little while until this whole COVID-19 situation gets under control. So we're pretty excited to do our first one online. We have been doing some interactive workshops on Tuesday and Thursday mornings that we've been sort of sending up to our YouTube channel. So if you're interested in learning more about active activities and staying healthy, you can check our YouTube channel for that as well. So Bell's been posting them up there. Eventually we'll probably be posting some of these as well. This one is going to be a little bit of a slideshow like we normally would do in the office and in front of you kind of face to face. And then as time goes on, we'll probably evolve them to become a little bit more interactive as well. But we're going to try and make sure we answer all your questions tonight. So like Bill said, if you have a non-urgent question, put it in the chat box. At some point, probably during the coffee break as well at the end, we'll just open it up and Bill will unmute all you guys and you can ask questions verbally as well. Because sometimes the chat box is hard to type out a question, especially if it's a kind of long question. But we'll get going right now if that's okay. So let me see if I can run this from my little laptop here. Our agenda for today is we're going to review some shoulder anatomy. We're going to look at the causes of shoulder pain. We're going to look at some common conditions that we see quite often in the clinic. And then we'll have a little mini coffee break. Belle and I kind of giggled and laughed because normally we love to feed you full of goodies and coffee and tea and stuff. But on virtual, we might just turn that into a short Q&A and maybe a little bathroom break, those of you that might need to go to the bathroom. And then after that, we'll probably get going right into the rest of the content. So in the second half of the presentation, we're going to talk about, how do we fix some of these conditions? And the first step with a lot of range of motion restrictions in a shoulder is stretches. So we're going to give you some key stretches. So that'll be the big sort of little win for you guys tonight, I guess, so to speak. So you can take home some stretches that we'll go over. And I'll demonstrate those in front of the camera here at home from my home office, so you can kind of go through those. So please do them as I'm describing them. Unfortunately, with the webinar mode, I can't see you. So Belle and I just learned the difference between a meeting and a webinar is that with the meeting, we can actually see you. So from now on, we'll be doing a meeting format so we can sort of see you guys do the stretches and sort of guide you through it a little bit better. We'll also be doing some draws at the end. So Belle's going to be in charge of that. So I'll close my screen and I'll let her open up. And you'll see we have, I think it's one free gift basket that we do, and we're going to do a couple massage draws as well. And those will be for Mariah, one of our new massage therapists on staff. If you want to see one of our other massage therapists, by all means, you can do that as well. And the massage service, just for those of you that are inquiring, will probably start up June 19th is the last date we had from the health minister. And she said phase 2 may start sooner if Alberta kind of behaves itself and the numbers are going down. So right now we're in phase 1 of the relaunch in Alberta, and physiotherapy was given the green light on May 4th. And so we opened officially on May 11th with all the health precautions in place. So it is a very safe, low risk place to come visit if you need to go in-house. We also have virtual online treatments as well that are available for those of you that are still a bit more apprehensive. We totally understand, and we can do online virtual. So I just met myself with 7 people this afternoon to do what we call tele-rehab. And so we went through and did some sessions with each individuals for about 30 minutes and had some fun this afternoon. So that was great. And the people are really enjoying them because it's in the comfort of your home, kind of at your convenient time. So it's actually, it's something we've just added and we're going to keep probably for the rest of my time anyway with Nose Creek. And then the last thing is 3 options for continuing to learn and manage your shoulder pain. So we'll talk about that at the end and how you can engage with us if you need some help or continuing your education, some opportunities and some content we have there as well. So action-packed time. Here we go. All right, so quite often I'll open my presentations. I like to survey the room and say, like, what kind of pain are you getting or experiencing in your shoulder? And typically patients will often say it's either constant throbbing pain or it's a pain that sort of comes and goes. It's intermittent. Sometimes it can be like a dull ache, and sometimes it can be really sharp pain, especially if they provoke it in an elevated position. Some older patients may describe cracks. That's usually just the AC joint, the top joint that we'll talk about, and we'll show you some anatomy pictures today. And pinching is often pinching of a bursa sac as you reach up, and some tendons as well. Giving way is usually a sign of instability or previous ligament damage. Clunking is usually a sign of your labrum, which is the cartilage socket, the ball part of the ball, the socket part of the ball and socket joint. And it often will fray and tear, and especially often seen tearing during dislocations. And often we'll get referred pain too. And if your shoulder becomes hypermobile, the arm will actually droop down a little bit, and that puts more tension on what we call your brachial plexus, which is kind of in your armpit. So you can get numbness right down into your fingertips with a really hypermobile shoulder. And then often people will describe limitations, and so we'll try to say, well, what do you function limited with your day-to-day life? And they'll often describe they're unable to reach for the coffee cup in the morning if there's so much pain in their shoulder. And lifting is just, they can't lift more than, like I was talking to one of my shoulder patients this afternoon, she can't lift a 5 or a 4 liter milk jug comfortably anymore because of her shoulder pain. And at work, they can't push or pull objects. Simple things like getting dressed, especially for females with bras, they can't reach in behind to do their bra up. Simply combing a hair can be a challenge for some people. And like we said before, reaching for that coffee cup is one of the most common complaints we'll hear from shoulder patients. So the anatomy is pretty, for us, it's simple as physios because we deal with it on a daily basis. But if you've never seen the skeleton of a shoulder girdle, on your left here, and I'll kind of use my mouse, this is called the clavicle, okay? and that's your collarbone. So when you sort of look at the top of your chest, that's the collarbone that goes over and attaches to the top of your, this is called the acromion, which is basically the bony roof of your shoulder, which is part of your shoulder blade, okay? And then we have the humerus, which is your arm bone, and that creates the ball. And then we have that socket right here. And you can see that the ball is actually bigger than the socket, and that's why shoulders are inherently sort of unstable and tend to dislocate. Just a little side note, I actually reduced a shoulder dislocation last weekend. I was out and about, and someone said that, hey, you're a sports physio, and then, hey, can you come help this guy? And so I jumped in his boat, reduced his shoulder, and then sent him off to the hospital for x-rays. When you dislocate, you often can chip and break this bone here, and sometimes you'll break these bones as well. And you can traumatize arteries and nerves. So that's why I always send dislocations to a hospital. So very important, if you have a friend or family member that dislocates, to make sure they go and get an x-ray done and get some medical work done. Oops, sorry, I just pressed one button too quick here. And then here's the muscles. So if we overlay the muscles into the shoulder blade, there's a supraspinatus, which sits on top of this, what we call a spine of the scapula, and it attaches right on the top of the humerus bone. And then we have an infraspinatus on the back that comes up here, and there's one underneath here called teres minor, and it attaches kind of in the back. And then in the front of the shoulder, in the front of the bone here, we're getting into the subscapularis. So there's 4 key muscles that basically, and the reason why it's called cuff is it basically wraps around that humerus like the cuff of a sleeve on your shirt. And it helps hold the ball in the socket, especially when you're overhead. And then here's a great example right here. You can see this of the labrum. So that's that sort of soft tissue that goes around the socket part that creates a deeper socket for us. So if it wasn't for that, we'd really be unstable in the shoulder area. All right, so that's kind of basic anatomy. And then if we look here too as well, again, it's a ball and socket, and we trade stability for mobility. And it's not just the ball and socket joint. So the glenohumeral joint is one of the joints, but we also have the scapulothoracic, which is a fancy word for shoulder blade on your rib cage. And then the acromioclavicular joint, which is at the very top of your shoulder, again, where your clavicle comes up to meet the top of your shoulder blade. And we also have the sternoclavicular joint, which is at the end of your collarbone, attaching right into the top of your chest, into that bony sternum bone that sits in the middle of your chest. So that there's quite a few joints actually in the shoulder. It's not just the ball and socket. And then I always talk about legions of disorders, because with the shoulder, there's a whole bunch of things that can go wrong. I used to do a presentation years ago, and I talked about there was like 40 things that would go wrong with the shoulder, you know, and so there's many things that can go wrong. And what happens as we age is we start to break down in the tendon area and the muscle area. And if we don't address these things, then there's just going to get worse. And so we develop inflammation in the bursa sac, which we'll show you in a picture in a few minutes here. The muscle tendon unit breaks down, and we progressively get tears. And eventually those tears, you get micro tears. If you get 100 micro tears, you get one big macro tear. And that's usually when your brain actually starts to register that something's wrong with your shoulder. So you can have fraying of these tendons for a long time before you actually become aware that you've got a significant sort of impairment in that muscle tendon unit. And again, if you seek help sooner rather than later, you're going to have healthier shoulders. And it doesn't really take much to hurt a shoulder. Like my wife last weekend said she was doing some yard work, and she was pulling some weeds, and she was also kind of worked out that morning. And then the next day she woke up and she couldn't move one of her arms, you know, and so she'd obviously overdone it. And it was probably pulling of the weeds, I would imagine, because she was kind of leaning back and really pulling hard. And so she strained a tendon in her shoulder, and it inflamed very easily. So it doesn't take much to hurt a shoulder. So if we break kind of the shoulder conditions down, we sort of categorize them into traumatic and sort of atraumatic. So the traumatic ones are the dislocations. And so that's when we have a slip or fall, or we get a blunt trauma to the shoulder where we get hit by something. And the ball usually will pop forwards and down in 90% of the cases. And in 10%, it will actually go back. The ones that go back is usually when you land on your hands. We call that a fall on outstretched hands. And the force is so blunt that it actually pushes the ball out the back of your socket. And so that's when you'll dislocate back. But most of them, like that guy last weekend, he was swimming and they managed to get him into the boat. He actually was laying there with it dislocated anteriorly. So I just did a gentle traction. You just rotate it back in, and then he was fine. And right away, it was like, whew, thanks, Blair. So, and then off to the hospital. So just so you guys know, that's the tip for that shoulder management. And for acute dislocations. Then some other things that happen, we sort of mentioned this before. So when you dislocate, what often will happen is you can break bones as you dislocate. So if you look here, we can see This is the tip of the arm bone, so there's a fracture there. And this is often referred to as a Hill-Sachs lesion, but basically it's just the top of the end of the bone hitting one of these bones, and one of these 3 bones will break, and sometimes it's that one first. You can see this one, there's a fracture of the clavicle as well. And here there's a fracture of the acromion, so the kind of the roof of the shoulder got broken. And how these happen really depends on the mechanism of injury and how you fall. If there's more force on that side, then it's probably going to break that side. If there's more force in the front, it's going to break that side. If there's more blunt trauma right to the top of the bone, then it's going to kind of compress that bone as well. And then again, that's why we always want to x-ray and see a doctor to rule out any bony trauma. And just so you guys know as well, if you have any friends or family that get hurt, a bone crack like this will result in a significant pain that's unrelenting. So it will not matter what position their arm is in, it's going to be a constant like throb, like it'll be boom, 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 boom. If it's more of a soft tissue damage, quite often it'll be more intermittent pain, where they'll just kind of move in a certain position, it'll reproduce pain. But when it's a fracture, it's a constant pain. So just to help you guys manage that if you're out on the weekends. And then so atraumatic, so causes of shoulder pain. So often when we're looking at people in the clinic, when we make them reach out to the side, we can get into what we call an impingement syndrome. And people with this sort of syndrome will often say that, you know, I'm good with my arms down at my side, but as soon as I start to reach overhead, I get a lot of pinching, you know, in the top of my shoulder and in the front of my shoulder. And what's happening is the bursa sac's getting squished, and the tendons underneath that acromial arch are getting squished as well. I think we have another slide later on that demonstrates that. Oh, here we go. So atraumatic, yeah. So here's the bursa sac that sits in there as well. And this gets really inflamed and puffy and will take up a lot of that little space. So there's not a lot of space between the roof of the acromion and the top of the sort of the ball and socket joint here, the glenohumeral joint. And the tendons all come, as you saw before, that supraspinatus comes right in here and attaches in here. And then we've got the subscap that's coming into here. And then we've got our posterior ones, our infraspinatus and our teres minor attaching in the back here as well. And so when we have an injury to a shoulder, if it's an injury to the tendon, we call that tendinitis. And that's usually, so we have swelling. Itis means swelling. So we have tendon swelling for about 3 weeks, okay, from a pulled tendon or a strained tendon. If it goes beyond 3 weeks, now we're into a different term called tendinosis, which you'll hear doctors kind of throw around a little bit. And so now that means that we're getting a mechanical breaking down of the tendon. We're now beyond the inflammatory process. And one of my dear friends came up with that term actually, and he did a PhD to show the world that after 3 weeks, we should not medicate these tendons anymore, because you're not going to help the swelling in the tendon. It's a mechanical situation that needs to be loaded for the tendon to rebuild. And so that's where rehab is so, so important. So we first started this with Achilles tendons when they would tear. He actually developed what they call a heel drop program. And then that was validated with other tendon researchers around the world. And that became kind of the golden standard for helping people with Achilles tendinosis. And then we applied that to tennis elbow, and we started doing that for people with tears in their tennis elbow, which is the tendon on the outside of the arm that we often tear when we grip and we lift something with a straight arm. And that's how we often hurt our rotator cuff tendons as well. So that's one thing, like after age 40, try to lift material, like using your biceps and keeping it close to your body rather than reaching out with a straight arm, because the lever there of the basic physics, the longer the object is further away from your body, the more torque you're going to put into your shoulder and elbow. So always try to lift with objects close to your body if you can. Good. All right. And then here's some atraumatic causes as well. So when we have things go wrong in the shoulder, one of the things, probably the most nasty condition you get in the shoulders is called adhesive capsulitis, is the medical term. Layman's term, we just call it the frozen shoulder. And so there's a gradual loss of range of motion, and there's increased pain in the shoulder, and it can take up to 9 months on average to resolve. Some people more, some people less. And so they've done tissue biopsies, and the capsule actually thickens. So there's been a trauma, there's a huge swelling, it puffs up like a big balloon. And then as that balloon kind of goes down in size and the body's trying to heal and kind of calm it down, that tissue starts to thicken, and that's what stops the shoulder from moving and starts to stiffen up that shoulder. So after you've had an injury, you do want to kind of immobilize it for a little bit of time, but then you want to get it going. You don't want to keep it immobilized, otherwise you're at risk for a frozen shoulder. All right. So we want to talk about the 5 things to help you and your shoulder. So that's what we just talked about actually with the frozen shoulder. So when you have an injury, you do want to be careful with your shoulder, and using a sling or a brace can be really helpful in the initial stages to stop the bleeding and stop the swelling in your shoulder. But this can lead to stiffness in your shoulder. So the key with the slings is you only want to use it for 3 weeks. After 3 weeks, you can now take your arm out of the sling. And that's what I told this fellow a couple weekends ago. I said, please sling your arm for 3 weeks to allow everything to heal up and to tighten back up. When I first graduated, 28 years ago, they used to tell us to sling those dislocated arms for 6 weeks. Well, recently they've done some research in Australia that showed there's no difference between slinging for 3 weeks and slinging for 6 weeks. So we tend to try to get people out of slings within 3 weeks. And most people don't want to be in a sling for more than about that time period anyway. It is really impairing of your function because you have to keep your arm tucked in. But when you first go into sling in an acute situation, it's like your body goes, oh, thank you. And when you put the sling on, make sure it actually pushes the elbow up a little bit to take the pressure off your shoulder and allow your shoulder muscles to just let go. Good. So the second thing is you can use ice, heat, or cryoderm on your shoulder. And we tell people whichever feels better. Now, the reason why we say that is, on a scale of 1 to 10, if it's kind of 6 or below, we usually tell people use heat. It's just kind of a dough like. But if it's 7, 8, or 9, or even 10, you probably want to be putting ice on your shoulder. And the other thing that we've kind of stumbled across over the last few years is lotion or ointment called cryoderm. And so it has some natural anti-inflammatories called arnica in them that will help with the swelling within your shoulder. And could often help just give you some temporary pain relief, especially in the acute situation in the first couple weeks after a shoulder injury. So we just sell that at our front desk now, and it's been sort of a godsend for a lot of our patients that have recent shoulder injuries. And then taking medicine. Well, for sure, if you see your family doctor, they're trained to treat you chemically, so they're going to recommend some anti-inflammatories to help reduce the swelling, which isn't a bad thing in the acute phase. We just don't want you to stay on those medicines for too long, because for every medicine there's a side effect. And so it's like in business, when I solve a problem, I create another problem. And that's kind of what happens with medicine. If you talk to most doctors, they know that, and that's usually why they'll say, well, just try that for 2 weeks, then come back and see me, because if it isn't working, they want you to stop that and maybe try something different, or they may start more medical tests. But the typical ones you'll see over the counter is ibuprofen. In layman's terms, we call it Advil. Naproxen is a pretty stronger anti-inflammatory. It's stronger than the Advil, and it's called Aleve. And then you can try some, if you're really having trouble with pain, to be honest with you, Tylenol will always give you more pain than Naproxen or Advil. Those are both kind of anti-inflammatories. And what we really believe in is the diclofenac. So it's basically Voltaren that's crushed up into a cream, and you can put that on your shoulder. And the great thing about that is it's going directly into the injured tissue. You're not taking a pill that's going down through your body, your digestive tract, through your kidney and your liver and all that kind of stuff. It's just going right where the injury is. So from an overall health point of view, I think diclofenac is actually more effective than taking a lot of those pills. So we really recommend the diclofenac and then the heat and ice if you can. But if it's really swollen and you need some help and you've got previous good results with these medicines, and that's totally up to you. Good. And then obviously with the shoulder, it sounds like common sense, but we ask patients to avoid positions and activities that are uncomfortable, such as lifting, reaching overhead, and stay away from sort of activities that hurt your shoulder. So I know it sounds like common sense, and people have to say to me, well, Blair, it hurts when I do this. So that I usually jokingly say to them, well, then stop doing that, And then they said, oh, I came to you for advice, and that's what you're telling me. And I say, well, for the first couple of weeks, you do need to slow down, and then we can get you back to some of those activities. And we often like to talk to patients about, hey, what are the top 3 things that you can't do right now that you want to get back to? But we can work you back to those things, but there's usually a few steps to get back to some of those activities. And it is definitely a process for shoulder rehab. Good. And the other thing is to, start physiotherapy. We can definitely speed up the reduction in pain by putting on machines like interferential and things like that. Get your flexibility back, get your strength back. You'll be taught exercises that are really productive for rebuilding your shoulder, especially those small muscles, those rotator cuff muscles that we highlighted in the anatomy slides. And these are things that you can add in and do on a daily basis. And some of them I usually recommend to patients, like especially anybody in their 60s, I'm like, you should do a pulley every day to maintain your shoulder mobility. And the tubing isn't a bad thing to do. And I usually tell my patients as I'm discharging them, this is stuff you can do instead of doing it daily, maybe drop it down to 3 times a week, but then twice a week the rest of your life, just to really keep the shoulder tendons and muscles strong so you can prevent further shoulder pain in the future. And and with every shoulder, it really depends on the severity and how long you've had the pain in regards to how quickly you recover. So if somebody comes in the clinic and says, well, I've had shoulder pain for about 8 weeks, then I tell them it's probably going to be a minimum of 8 weeks and maybe more, as long as you're compliant to this program. But most shoulders, to be honest with you, on average take about 12 weeks before they start to feel half normal again, right from the acute injury and then starting the rehab process. Some can take up to 16, but certainly at 16 weeks, if we're not happy with the progress, then we're recommending further testing with your family physician. And even before that, we'll often send people for ultrasounds and things like that, just to give us a better idea in regards to what the prognosis might be with the shoulder injury. And if you may need surgical repair down the road. Okay, wow, so there we go. So there's our first little bit that we talked about for some anatomy and things like that. So now we're into our official coffee break. So does anybody have any questions based on the content so far? Belle, do you have any questions in the Q&A?
None yet, but we can
Okay.
invite them to put in their questions.
Sure, yeah.
Box. Or you can unmute yourselves, guys. And you can just shout out the question. No questions on my end, Blair.
Okay, super duper. And if everybody's okay, you don't need a bathroom break, then I'll just continue on.
Actually, sorry,
Oh.
am I unmuted? Hi.
Hi, Stacy.
Hi. I just had to get to a little bit of a quieter location. As you can imagine, during these times, everybody is in a similar house on technology. I had some questions actually about rotator cuffs.
Okay.
And I have an elderly parent who has a torn rotator cuff, and I'm trying to understand the condition a little bit better and kind of have an idea of how I can help him.
Okay. How old is
Managing pain.
Is it your dad then?
Yeah, it's my dad.
Okay.
He's 72.
Okay. And
Yeah,
then
and-
when was he diagnosed with the rotator cuff tear?
In like the last 3 months.
Oh, okay. And
Yeah.
on a scale of 1 to 10, kind of where is his pain at right now?
It's probably not even on the charts. He needs a lot of help every day.
Okay.
It's his right rotator cuff.
Okay.
So he's right-handed. It's a terrible dilemma he's in. So he is waiting for surgery, which I understand, hopefully will alleviate some of the problem. But I guess it's really, like I said, kind of understanding the injury, and is there some things he could think about doing as he's, waiting for surgery or prepping for surgery that might help with some of that pain?
Yeah, so in the slides when we talked about the 5 things you can do, those are 5 things you could apply to your father. Let me see if I can just bring this back real quick here. So he could preoperatively even do a little bit of physiotherapy if he wanted to, but if we kind of just put this back here, so first of all, slinging his shoulder, if he hasn't had his arm in a sling, he could try that during the day, and he might find that he gets a bit of relief with that. Just to kind of stop any excessive movement or tearing, because if a tendon's torn and if it's fully torn, you won't get any pain because it's completely disrupted. But if he's got, and what happens is you'll get some that tear fully and then some that are partially torn. It's the partially torn ones that are causing him all the pain. So at this point, if he could sling, that would certainly help him. And you can just go to like London Drugs and buy a sling. I bought one for my wife because she hurt her shoulder really bad a few months back, and I think it was on sale for like $20. And it was actually a tiny little box. And I thought, oh my God, how'd they fit the sling in this little box? And it actually folded out into a really nice sling that had kind of the sling part was aerated, so it breathes really well. And so that might be something that you could buy him, and he might get a bit of pain relief with that for sure. And then certainly if it's a sharp pain, you should be icing it. If it's a dull ache, he should be heating it. And he can alternate between sort of heat and ice. And the cryoderm, again, is something that would give him some instant pain relief because there is a bit of an analgesic balm in that, so that would kind of warm either, it would, instead of him having that constant pain message to his brain, he would get kind of a nice soothing, either hot or cold, depending on the response from the cryoderm that he gets from his skin. So as long as he's got healthy skin, you could rub some of that on him on a daily basis. And patients will often put it on like twice a day, kind of once in the morning if they're sore and once before bed, so that the increases. The big thing is, a lot of my patients often say to him, it's almost, the cryoderm is almost like a sleep aid. And I tell them, put it on right before bed if you can, and wrap a heating pad over your shoulder, and you'll just kind of relax your shoulder so you can fall asleep more comfortably. The medication is
Wow.
obviously something you can talk to your family physician about, but I would actually ask your family doctor to write a script for diclofenac as well, because the diclofenac cream, he can actually put that on, or you could put that on him. And I believe it's usually twice a day is what the prescription is. And that's going to get the swelling right where we showed you in that diagram, underneath those bony sort of landmarks. And it's probably the bursa sac is really inflamed and could be bleeding as well in the rotator cuff tendon. So that would be a bonus. And then just getting him to really rest it and avoid positions that are causing pain. With rotator cuff tears, like, can he even move his arm? Can he move it up at all, or how far can he reach forward? If like
Well,
0's at your side and 90 is at your shoulder height, how far can he raise his arm?
he actually has to use his left arm to raise his right arm to eat.
Okay, yeah. So then he's definitely
Yeah.
had a lot of rotator cuff tears. Has he been for an ultrasound yet?
I
ultrasound his
believe
shoulder?
yeah, I believe
Okay.
he has.
Okay.
And I mean, you know, he lives in Quebec.
Okay.
So yeah, so I'm kind of from a distance trying to, you know, figure
him
out
out.
some ways I can help
Yeah.
him. Yeah.
Well, there you go. So, you know, most of our medical docs here will actually do x-rays to rule out bony trauma first. And then the next thing they'll do, if the person isn't progressing, is do an ultrasound. The ultrasound technology has really it's really increased the last, I would say, 10 years. So in fact, the surgeons love it because it actually will give them the exact precise area where the tear is, the depth of the tear, and the width of the tear. So they can actually ergonomically measure the location. And then as far as surgery goes, like my mom fell out of a chair, just slipped and fell out of a kind of like a chair like I'm sitting on with wheels when she was 65 and completely ruptured her supraspinatus tendon in one shoulder. And she did see one of our local surgeons, Dr. Borman. And so I remember chatting with him and I said, well, what are your outcomes with, you know, like 65-year-old females? And he just said, Blair, it really depends on their anatomy. And he said, fortunately, your mom's a swimmer. Because she's a swimmer, she's got strong shoulders. She's got lots of muscle there that we can reattach. Whereas some of my patients that are 65 and up come in and they're really frail and there's not enough tissue to even, you know, reattach. So again, that'll be a surgical decision that the surgeons will make probably with him.
Oh,
So
Blair, this has been, yeah, really great.
Yeah.
You know, you've given me at least some direction
Yeah.
in terms of even a conversation I can have with my dad.
Yeah.
So this has been really great. Thank you.
Oh, you're very welcome. And yeah, I would, I'm trying to remember the name of what city is he in Quebec?
Well, he's in a small rural town called Esquimanac, and it's actually a border town with New Brunswick. So his doctor is not a Quebec doctor; it's a New Brunswick doctor.
Okay.
So his surgery is being delayed because the border is still closed between the two provinces.
Oh, I see. Yeah. So just I would just network around there and find out like who's the best kind of sport physio in that area, and then get your dad in to see the physiotherapist, because they could probably put some modalities on it just to get the swelling under control and hopefully give him some pain relief while he's awaiting his surgery. And they
I
could talk
will
about
look into that.
positions for sleeping, and there's all sorts of things we can do as therapists to really get people's pain under control. So yeah, so best of luck with that, and feel free to email me or contact us if you need some more follow-up. I don't mind doing that.
Thanks. I mean, you folks have helped me a great deal in the past when I was at your clinic for various issues, and so I'm on your mailing list, and I got this invite, and it was perfect timing. So thanks again, Blair. I appreciate it.
You're welcome, Stacy. Yeah, well, keep me up to date. I'd love to help your dad out if we can. And then if you need to find a therapist, you're having trouble, we can try and network to find one for you too.
Oh, that's awesome. I'll keep you posted. Thanks.
Awesome. Well, you're welcome. All right, guys, we'll jump into the next portion here so we can try to keep it on time. So when to start exercises? Patients will often ask me that. And what I tell patients is that you want to make sure you give the shoulder like 14 days to really calm down. So like if you got a relative that's just dislocated their arm, they really want to slow down for the next 14 days. So don't be doing anything with the arm. Let the arm heal, because the more you move shoulder, the more you cause bleeding and the more you cause swelling. And that's going to delay the overall recovery. We really want to take 2 weeks to let things kind of calm down if we can. And then if you start physiotherapy, we're going to get some modalities on you, just like I was telling Stacy, that are really going to speed up that whole healing process. And then we can give you the appropriate gentle exercises and gentle stretches to start mending your shoulder up. A lot of people, they Google stuff and they start getting into, you know, other sort of avenues of treatment, and they often make themselves worse in the first stage instead of better. And in fact, they lengthen their time of recovery just because they're not doing the appropriate exercises. And that's the problem we see with a lot of patients that'll come in with chronic shoulder pain is if we'd seen them early on and sort of given them like a little bit of a protocol, they probably would have had a faster recovery. And it is kind of a gradual recovery of shoulders, and you do have to base it on the intensity and the duration of exercises. So there's a lot of exercise prescription that kind of goes with shoulder rehab. So at Nose Creek, we like to look at modifiable risk factors for solving shoulder pain and restoring your function and getting you back to what is important for your lifestyle. And that's why we always like to say, what are your top 3 whys that we need to fix your shoulder for? So I'll just give you a quick list, and this is not to overwhelm you or anything, but these are the kind of things that we look at. So we look at your overall kind of flexibility. We look at your tight pec muscles, your tight lat muscles, which tend to give us a rounded shoulder posture. And we look at the weakness in your shoulder girdle, both between your spine and scapula, which is your scapular platform we'll often refer to, and and the weakness between your arm bone and your scapula, which is more, again, your rotator cuff and your deltoid. And we look at the weakness in your upper back and your neck muscles, because that's part of that upper quadrant chain. And we'll often look at your reduction in what we call proprioception, or your coordination of your arm in space. When you've had a bad injury, especially like Stacy's dad, he can't move his arm actively. He's going to have to learn how to use his arm again once he gets it repaired, if he does not go on for a surgery. And so that's really important, and we can teach people that in physiotherapy. And one of the common things we see, especially with atraumatic shoulders, where there's been no history of dislocation or trauma, is we naturally kind of round our shoulders up, and we end up with a tight posterior capsule. And if you can imagine the capsule, attaching to that socket, it gets tight in the back of the socket, so it pushes the ball forward in the socket. So the ball doesn't actually pivot in the middle of that socket anymore. The ball is actually sitting kind of pivoting on the front of the socket and kind of rubbing on a bunch of tendons in the front. And so that's why a lot of people complain of anterior shoulder pain, because of that sort of capsular imbalance we develop. And then we have sometimes reduced stability, and that's could be congenital or it could be acquired. So congenital means like you were just born with that. You might have friends or family members that can take their thumb and twist it all the way back to their forearm, and when they put their elbow out straight, it kind of bends backwards. And those are people that are we term hypermobile, and those people are at high risk for a lot of sort of joint pain as they age, because of the hypermobility. And acquired means that they had the fall or the dislocation, opposed to somebody with really tight sort of capsulitis, and that's more like the frozen shoulder. And then we look at the porobiomechanical movements. So often when people have shoulder injuries, instead of lifting their arm up, their shoulder girdle will kind of hike up at the same time. So we call that reverse glenohumeral rhythm. You'll often see that in the clinic when people first start with us. And then we often need to functionally change kind of the way people use their shoulder girdle to prevent future problems and chronic conditions that can continue. And then again, we're going to look at the inflammation and where they're at with that. And again, diclofenac is probably the best thing we can get going with that, as well as interferential and other modalities that will kind of stir up the circulation within the shoulder. And then again, smoking. We always mention that. We don't harp on people about smoking, but it does reduce your blood's ability to carry oxygen to the healing tissue. So if you have 2 shoulder patients, one that's a non-smoker and one that's a smoker, the non-smoker will always heal faster than the smoker, just for that simple reason. So we just encourage people to try and stop smoking if they can. The last time I looked, when I did research on smoking, it was related to 27 different systemic diseases. So just saying that to some people makes them think twice usually about whether they want to continue that sort of habit. And then obviously excessive texting. So, we're seeing kids come into the clinic with atraumatic sort of pain in their necks and shoulders from being bent over their phone all day long. So careful of that, because that does lead to neck issues as well. And then postural issues, from your shoulder. And we'll talk a little bit about some stretches today that can hopefully start you down the road to adjust your posture as well. Good. And then what to avoid. So that's why we have the big stop sign here. So in the gym, and I don't have my camera on right now, but just remind me, Belle, to talk about these movements. So these are the 4 things that I try to train people away from. So military press basically is, imagine if you have your elbows out to the side and your elbows are bent at 90 degrees and you're pushing a bar above your head and kind of bringing it down to your shoulders. That is the dislocation position, that 90-90 position. That puts a lot of pressure onto your anterior capsule. So it's not a great exercise for the shoulder if you're doing it repetitively every week. So you want to keep people away from doing that. Upright rows is when you grab a barbell and you kind of pull it up and your elbows are above your shoulders. Anytime your elbows are above your shoulders, that creates a position of impingement. So that's just fraying away at those rotator cuff tendons and squishing that bursa sac, causing it to swell up and sort of slowly break down your shoulders. Dips are what you've seen people do before, where they actually have their hands on a bench and then they're lowering their bum below the bench and then they're pushing back up. Dips are great for building up chest and triceps, but unfortunately they break down the front of the shoulder and your AC joint. And then a wide bench press with a bar is really hard on the front of the shoulders, especially if you're going way back into hyperextension. So for that, we often tell people, if you like the bench press, just use dumbbells instead, because now you have to proprioceptively control and balance those dumbbells as you're going up and down, rather than levering a big bar that's causing excessive stretching in the front of your shoulder, or what we call your anterior capsule. So interestingly enough, a lot of these I think all of these 4 exercises were developed by Arnold Schwarzenegger during his glory years when he was the big bodybuilder. So, and ironically too, he's had rotator cuff tears, over the years as well. During one of the filming of, I think it was one of his Terminator movies, he did something simple, and he said, "I couldn't believe my shoulder got really sore." And so that was all that fraying from all those years of weightlifting that kind of caught up to him eventually. So we'll just move on. And then lifting with straight arms. So we talked about this. One of the common mechanisms for rotator cuff tears that I hear from guys, especially in the spring and in the summer, is they say, well, I just kind of reached over, I grabbed my golf clubs out of the back of the trunk and I just kind of lifted them up with straight arms. And all of a sudden it felt like one of my arms just had a sharp pain in it. And I had to drop the golf clubs. And I was like, what the hell happened there? And so I described to him that you probably had a rotator cuff tear because you're lifting with your arms straight. And I always make the analogy of with groceries as well, grab them and try to get as close as you can to the vehicle and lift with your biceps and your legs. Don't lift with the straight arms if you can. And then for sleeping, you don't want to sleep on a painful shoulder. You want to avoid that. And basically the resting position for your shoulder, and this is another great tip for your dad, Stacy, is you want to put the pillow underneath your arm. So take a pillow, fold it in half, and then shove it up underneath his armpit, and then just let him kind of lay like that. And he can lay on his back with his arm in what we call the resting position, and both on his back and on his side. That's a really great position for a painful swollen shoulder. And then never sleep with your arm above your head. If you can, if you're laying on your side, try to not let your elbow go above your shoulder if you can, because you're impinging tendons and bursa sacs, and you're also probably stretching your brachial plexus if you're kind of sleeping with your arm above your head. So try to avoid that if you can. And then, so if you do happen to slip, we don't see as many slips in the summer as we do in the winter, but you'll end up with what we call a fallen outstretched hand. So if you are slipping and you go to reach for something, if you know you're safe, it's better to kind of tuck and roll if you can, because when that arm is out, it's really vulnerable to being dislocated. So try to, if you can, kind of tuck your arm in and take the blunt of the fall kind of on your side or the side of your shoulder rather than your arm straight out. Good. And then so stretching principles. So we're going to go over the stretches in just a couple minutes, but I just want you guys to understand that it's really important to warm up your muscles before you stretch them. If you just got out of bed and you're kind of cold and you just do a stretch, your muscles aren't going to be ready, and they're not going to be supple and elastic, and they're not going to give that nice little stretch. So our principles that we always talk about in rehab is you want to hold for 20 to 30 seconds. You want to repeat twice if it's tight, is my general rule. And usually for the first 2 to 3 weeks, you're going to want to do them twice until you get that natural length. And patients often say, they say, oh, geez, when I do that doorway stretch now, but I don't really feel much anymore. I say, well, congratulations. That means you've now got normal length. Now you just want to maintain that. So just do 1 repetition. And you can sort of cut your stretching time in half, certainly after 3 weeks. And then when you're stretching, you should not feel any sharp pains. You just want a strong muscular stretch. That's really important. And I always tell people that stretching is a journey. It's not a race. Like, you just slowly get that tissue length back. Don't expect to get it back in a week. It does take time to change those tight muscles. Good. So the first step to gaining range of motion, like we talked about before, were the stretches. And there is a handout that we can send to all of you. So Belle has got all your emails. So if you want this handout, just contact Belle at the end of today's session, or send her an email, and then she can send you the stretches as well that we can give to you for home. So we're going to talk about, first of all, the front of the shoulder, a pec stretch, what we call a doorway stretch. Or if you get pain in that position, we'll show you an alternate to that called the corner of the wall stretch. Then we're going to do a tricep stretch. And the tricep stretch is hitting the bottom of the inferior part of your capsule of your shoulder. And then the most important one, I think, is the posterior or the back of the shoulder, which is your rotator cuff stretch. So we're going to go through all 3 of these right now. So I'm going to see if I can stop my share. Here we go. Excellent. And then, can you guys see me? There we go. Okay, good. So here we go. What I'm going to do is I'm just going to get rid of my chair. And then we're going to come back here. So the first stretch, what I want you guys to do is actually get out of your chair if you can. It's time for you to stand up. You've been sitting too long. I apologize for that. You're going to go up to a door frame. And what I want you to do is put one foot through the door frame. And if you can, put your forearms on the outside of the door frame. And then I want you to lean your chest and your hips through the door frame. So from the side, it'll kind of look like this. Now, what I don't want is a lot of people do this. That's just kind of stretching the top of your shoulders. You actually want to take your whole trunk, kind of pelvic tilt, tighten up your tummy, and lean your hips and your shoulders through that doorway so you really open up your chest. Once you get into that stretch position, now I want you to take a big breath in. So it's big breath. Inflate those lungs as big as you can. Hold the breath for a few 5 to 7 seconds if you can, and then breathe out. As you breathe out, try to lean a bit further through the doorway, and you should get a massive stretch of your chest, especially the top half of your chest. Is anybody doing this right now? Bill? Or everyone's muted right now? Okay. It's hard to see. Unfortunately, I don't have any pictures, so I can't check on you guys. So I'll trust you're all doing it. That's good. Okay, excellent. I am. Jody says she's doing it. Okay, thanks, Jody. Okay, good. All right, so the next one basically is tricep. So what you're gonna do is you're gonna put your hand on your shoulder. I want you to reach over the other one, just pull that arm back as far as you can. So you get a big stretch in this area of your arm here, which goes right down into your armpit, okay? And just lean back and just gently stretch that. And again, we're gonna try to hold that for a good 20 seconds if you can, okay? And then always do both sides. So maybe we'll do the other side here as well. So these ones are done kind of one at a time. And again, you're just holding and just gently letting that tension go. And for me right now, I feel lots of tension in that tricep because I did a little mini workout this morning and did some push-ups. So that's going to really work that tricep. There we go. And just sort of breathe and try to really relax into it. So some people enjoy just breathing in through the nose and out through the mouth and just kind of letting things kind of relax. Don't hold your breath while you're stretching. Some people tend to go and they hold and they kind of strain like that. You want to, whoops. Knocked my headset off. You want to keep breathing naturally if you can. Don't hold your breath, okay? And then the last one, which I think is the most important one for the rotator cuff, is you're going to take your arm, okay? So I got my arm at 90 degrees now, like that, and I'm going to slowly grab the underside of my arm, and I'm just going to pull my elbow across my chest, and then slowly let the arm rotate down. So my wrist hits, it just kind of goes by the outside of my shoulder here, okay? And then from there, if you don't feel a stretch, just very gently take this arm now and just gently pull it across just a little bit more. And you should feel a really big stretch in the back of your shoulder here. So this is the tissue we're trying to stretch here. So this is actually stretching your rotator cuff tendons in the back and your posterior capsule, okay? And again, let's try it on the other side. So elbow at 90, and we're gonna pull across and then let it rotate down and then just slowly pull across a little bit more. And you should feel a nice healthy stretch in the back of that shoulder, okay? Now, if some of you are getting a sharp pain in the front, then we probably need to have a look at that. But the other thing is, for now, if you're just starting the stretching, if you've never done those stretches before, then you want to make sure that you don't sort of push too hard. So be careful. You want to feel a stretch in the back, but no sharp pains in the front. Okay? Let me just go back here now. Go back to my share screen. Perfect. Hey, it's working pretty good. Bill, I think I might pass my test tonight. Okay, next one. Oh, okay, why is it moving forward? Oh, we seem to be jammed up here, Bill.
You're right. Press your right arrow.
Yeah, doesn't seem to work now. Oh, that's strange.
Hit escape,
Okay, yeah, I'll have to go out.
then go back again.
Oh, well, that's weird. Oh, hold on. I have to press escape on my laptop. No, that's weird. Okay, stop share. Share screen. Share, comes back. Escape. Oh, that's weird. We seem to have jammed up. You're sharing screen.
Did you hit escape?
Yeah, when I hit escape, nothing happened, so it just kind of stopped. Pause share.
Stop sharing and then open the file again.
Okay, that's strange. Exit full screen. Okay, there we go. So the next slide has us doing some video testimonials. So what I'm going to do here is I'm just going to come back, and then that's the draws. So Bill,
Yep.
I'm going to, I think I've stopped my share. Yeah. Can you take over and do the video testimonials for us?
Sure. We have one. Give me 1 sec. I'm sharing my screen. Can you see Joy over there, Blair?
Unfortunately, I am in my PowerPoint trying to get back to the, oh, there we
Guys, I
go.
have Joy here. She's one of our patients who would like to share her experience with her shoulder.
Hi, my name's Joy. I came to see Blair back in 2006 when I broke my right shoulder. And he had me back and full range of motion in an incredibly short amount of time. Like within 6 months, I think it was even less. It was a long time ago, so I don't remember it 100%, but it was amazing. And then unfortunately, I had another accident just last year, and I broke the left shoulder. And so right away, I knew I would come and see Blair again because he is so amazing. He just gets me back in the game of life so quickly. This time it's been a lot harder, but that has not been on Blair. That's just been because of the injury. It was more severe. And so yeah, if you are needing physical therapy, this is where I highly recommend you to come. Blair's the best. Thank you.
Okay, and then I have one more. We do have, what's her name again? I have Jane. I will let you guys meet Jane. Give me 1 sec. This is Jane. And by the way, Blair, you have to remind me later. We have two questions.
Jane Carroll.
Okay.
And I started coming to see Blair back in October, which is about 8 months ago now. I have been diagnosed with Lyme disease. I was literally bedridden. And to top that off, I ended up with frozen shoulders. So I had to wait a few months before I could get any treatment. I did see another physiotherapist before Blair, and I ended up in more pain, and it was basically getting worse. I was highly recommended to Blair through my NUCA chiropractor, and he strongly suggested that I come to see him. And am I ever glad I did, because it's changed my life. I drive right across the city. At first, I couldn't drive. My husband had to drive me. With the frozen shoulder, I couldn't brush my teeth. I couldn't comb my hair. I couldn't even shave my armpits. I know that's getting personal, but it's true. So they told me it would be minimum a year. It's been 8 months, and I feel like I'm at least 95%. And I'm so happy that I've kept coming here. I was coming weekly. I come about every 3 weeks now. I also get massage from Bernadette, who has magic fingers. And everybody here, when you come in, you're totally welcomed. The atmosphere is people wanting to help you in your hour of need. And I really, really appreciate that. So that's about all I've got to say. I'm doing great. I couldn't do this before, and now I can. Woo! So if you have a chance, or if you need help, I would suggest starting here first. Thank you.
There you go.
Awesome.
Your 2 shoulder patients.
Thank you, Bill. Now, how do we get back to sharing the screen?
Hang on.
Oh, now you got Tom coming in here. There you go.
There you go.
Share a screen.
And there I have 2 questions.
Okay,
When you're ready, just let me know.
sure.
I'll read to you
Um,
2 questions one from Wendy and then one from Janice.
okay, sure. Yeah, we can do them, and then we'll do the draws after that.
Sure. So
I can't see
Wendy
Wendy.
has a question here. I will read Wendy's question. I've had
Sure.
a shoulder replacement, but still
Yeah.
experiencing pain in certain positions. Still
Okay.
have reduced motion as well. Have sleep disruption because of this.
Okay.
And then from
So
Janice.
can you get her on the? Can you open up her or unmute her?
Yeah, for sure. Where's Wendy? Wendy. Hi, Wendy.
Is Wendy's mic working? Maybe not.
Can you hear me?
Oh, hey, Wendy.
Yes, Wendy.
Can
We
you
can
hear
hear
me?
you.
Yeah.
Yeah.
Oh, good. I have never used this thing before, so this is new to me.
Yeah, that's okay. No problem. It's new to a lot of us too. So could you repeat your question to the group?
I have had shoulder surgery,
Okay.
and I'm still experiencing quite severe pain in certain positions.
Yeah.
And also, when I sleep at night, I have to roll over constantly.
Okay.
And I do try to sleep with a pillow underneath my arm.
Okay. Now, so your question is, how can you modulate your pain at night?
Yeah, I guess that I'm a little bit upset because this surgery hasn't been as successful as I thought it would be. I guess I have a range of motion problems and that kind of thing too.
Okay. And when was your surgery again, Wendy?
Well, a couple of years ago now.
Oh, it's been a couple years. Okay, yeah. Because it is, with a replacement, it's definitely a journey, and it can be up to 1 year before your shoulder or your knee or your hip, depending on the body part, will feel normal again.
Right.
And certainly if it's been 2 years and you're not happy, then it's the type of thing we're probably going to have to get you into the clinic and have a look at you and get a real sense in regards to where you're at with your range of motion and your strength. And there's a lot of kind of modifiable risk factors that we'll definitely have to have a look at.
Okay.
But again, for sleeping at night, just like I was mentioning to Stacy, try the pillow. If you tried that, try the cryoderm before bed as well. That might be another thing that might help you at least get to sleep for a few hours. The first 3 hours. Go ahead.
Often use Aspercreme or a Kalea pain relief too. Yeah.
Oh, good. Does that work good for you?
Yes, it does.
Oh, good. Yeah. So the great thing about the analgesic balms and the anti-inflammatory creams is, again, you're just putting it into the tissue where the injury is versus taking a pill that goes all over your body.
Right.
And sort of gives your liver more of a load.
Exactly.
Yeah. So your answer is, your question rather is kind of challenging without actually seeing you in person.
Okay.
So yeah, I'd love to get you into the office, and if you can't see me, then one of our other team members, we see lots of shoulder patients, so we'd be happy to have a look at you and sort of maybe just get you back on the road to recovery. I know sometimes replacements. Oh, okay.
Yeah.
Then we might have to do what we call a virtual, and then we can do sort of virtual assessment. We'll look at your range of motion. Shoulders are actually, I just assessed 2 shoulders online this afternoon. They're actually pretty easy to assess, especially if it's something like yours where there's been a replacement. So all the work has been done already. So then we're just going to look at your modifiable risk factors, and we could certainly help you out with that. So you could contact the office and talk to Bell, and we could definitely, do an online sort of tele-rehab session with you, and at least get you back on track and get you started, like I say, down your road through your recovery and feeling better.
Thank you.
Yeah, you're very welcome, Wendy. So hopefully we'll talk to you soon.
Okay.
And then what was the other question, Belle?
It's from Janice.
Okay.
Janice, are you still there?
Yes, I'm here.
Oh, there she is.
Hi, Janice. Can you repeat your question for the group?
Sure. My sister, it's actually about my sister. She's had rotator cuff problems for many years now. It's never fully healed, but she's actually experiencing pain now in the bicep tendon. So I was just wondering if you had some kind of stretching exercise or something to help relieve that pain she's experiencing there now.
Oh, for sure. So actually, I would actually show her the 3 stretches we just did here tonight.
Okay.
And we can send you, Belle can send you a handout with these 3 stretches on them, and pass that on to your sister. Get her to try those to actually stretch the bicep tendon. Let's see if I can take myself off the hold on here. Unfortunately, I think I've got myself mixed up here.
Are you trying to stop the share?
Yeah.
Yeah, it's
Just
just
stop share.
There.
Okay, there we go. Perfect. Okay. So for the bicep, there we go. Too many buttons for me, Bill. Good thing Bill is here. So what I'll often tell patients that want to stretch their bicep is you actually take your hand, see if I can do that. This is kind of my messy office here, but you're going to put your hand up on the counter, and then you want to kind of lean your hip into your elbow. So if my hand was here, I'm going to actually push my hip into my elbow, and so you're creating a real strong stretch in the front of your elbow, but that's actually going to stretch your bicep tendon as well. Okay, and then some people will take their arm back and they might put their arm here and they'll come forwards this way, and that would stretch your bicep tendon as well. So those are 2 techniques you can use to kind of stretch that anterior bicep if it feels like it's tight. But if she does that stretch and it generates pain there, then she should probably get that looked at. Because if a tendon's inflamed and you try to stretch it aggressively, it'll often reproduce more pain. If a muscle is just tight and you put it into a stretch position, it should just feel like a muscle stretch. So it shouldn't be in a lot of sharp pain. So that's often, sometimes when I'm dealing with people online, I'll say, well, you know, if it's just a normal stretch, that's great. But if every time you do this, you get a sharp pain in the front, then I think we need to have a closer look at that. And I usually say, let's get you in the office next week and have a closer look at that tendon. Yeah. Does that make sense?
Yes,
yeah,
it does.
So one is the hand is on the counter, just lean your hip in to straighten your elbow. And the other one is put the hand back and then just kind of straighten up to really get a good strong stretch through the front of that bicep. So your arm goes into a backwards kind of extension position. Good. Okay, Belle. So I'll let you take over the screen now. And Belle's going to do some draws for us. Bill, you got to unmute.
I got it. I'm just checking if
She's
all of
usually the
yours
one yelling at me
here.
going, I can't hear you, Blair. Yeah.
Okay, so our first draw. What's the first prize, Blair?
It's for the free gift basket.
It's for the basket.
Okay.
And our winner is Melissa.
All right. There you go, Melissa.
Oh, Melissa.
Congratulations.
You can pick up your gift basket when you get back to the clinic this week.
Awesome.
And then our second draw is massage gift certificate, and you may redeem the massage service when it's back in June.
Yes.
I can actually book ahead already.
Yeah, great point actually, Bill. So we are, when people ask about massage, we're pre-booking them tentatively kind of in the latter part of June.
Yeah, so the lucky winner of a 60-minute massage is Manju.
Hey, super.
Manju,
congratulations, Manju.
Manju, I will email you. I think she's still here.
Yep.
There she is. Manju, if you're listening, you want a
Thank you so much.
You want a 60-minute gift certificate, and I will email you details.
There you go.
That sounds really great. Thank you so much, guys.
You're welcome.
That was awesome. I will definitely see you there.
Super. Okay, Belle, do you want to do one more massage one?
Yeah.
I feel like I'm in a good mood. Let's do one more.
One more.
There we go. One more lucky winner.
The lucky one is Jody.
Jody Bond. Hey, congratulations, Jody.
We'll see you soon, Jody.
Awesome. I've missed you guys.
Yeah, we missed you too.
Thanks.
That's great. Perfect. Well, thanks, Belle. Awesome. Okay. Belle, can you get my screen working again?
Sure.
So if I share, I'm in the, how do I get into
Click
the other, this
click
one right
on-
here. I think I'm back into the show.
Yeah.
Click, there it is. Okay, guys. Whew, made it. Okay, so we got that section done. We'll move on to the next slide. So 3 options. So 3 ways to engage with Nose Creek. So for those of you that are just sick and tired of that shoulder pain that's keeping you up at night, waking you up when you do in the morning, and just hurts whenever you're doing activities that you want to get back to, you can just contact Bell and book a full assessment in the clinic, and we can definitely have a look at you right away. If you have some specific questions and you're not really sure if physio is the right thing for you, we'd be happy to jump on what we call a sort of 15 to 20-minute virtual discovery visit, and we can chat with you and we can sort of set some goals, and we can also screen to see if you're appropriate for physiotherapy. Some people come to us and they want to try us out, and when we do that discovery visit, often we're looking for red flags that need to be kind of ruled out first. So sometimes we'll actually send your family doctor for some medical screening first before we start the therapy, just to make sure that we've got some stuff ruled out. And it just gives us a chance to get to know you and set some goals with you and figure out, why we need to fix that shoulder. And then the other thing is, if you're just starting the journey for shoulder pain and you just want to learn more, just go to our website and download our free report from the website at www.nosecreeksportphysiotherapy.com, and I'll just show you that in just a sec here. Or you can often email Belle and she can send you that report as well. And I'll just take the slide one step further here. There we go. So that's our website. I apologize for the color there. I must have done that one, Bill. So www.nosecreekphysiotherapy.com, and then that's our phone number, and our current location is the Beddington Co-op Shopping Center. So I just want to really thank everybody for attending tonight. And is there any other urgent questions before we close tonight, Bill? Bill? Oh.
Let me check. There's one from Arlene.
Oh, super. Okay, so shoot. Or do you want to unmute Arlene?
Hi there. It's actually
hey, Arlene.
Marlene. It's actually Marlene, the skateboarder. We're watching it together. Hi, Blair.
Hey, how's it going?
Good. So I had some physio with you guys probably 2.5, 3 years ago. No, maybe about 2 years ago. And it was my second session of physio. I had a really bad fall and I have bursitis as a result.
Oh,
and
no. Okay, yeah.
I was sent to a sports med doctor, and I got some a rec for cortisone.
Yeah.
And I've had 2 rounds of cortisone, but I seem to have chronic shoulder pain now, and I'm not sure, should I go back and get another ultrasound? Should I apply heat? I use diclofenac all the time. I have a prescription for that.
Okay.
So I'm just wondering, like, what's the next steps? Because it's always kind of there, and even small tasks like a little bit of gardening hurts it. So just wondering what to do next, or if there's any hope. And I don't want to really do cortisone again. I've had 2 rounds. The last round didn't actually do anything except give me a lot of pain. So anyway.
Yeah, so great question, Marlene. I'm glad you brought that up. There's an explosion of interventional radiology that's going on sort of right now in Canada, and Arlene would know this because she's in that profession. And so I think the chemical stuff, from my point of view, is good. It will give you some relief, but unfortunately the chemical stuff is really short term. They did a study on tennis elbow a couple years ago, and the people that were injected with cortisone in their lateral epicondyle and extensor tendons were brought back a year later, and compared to people that just kind of did conservative management with physio and things like that. And the people that were actually doing the cortisone, they were functionally worse than the people that were managed conservatively with just physiotherapy and home stretches. So in some cases, and I don't blame people, like if your pain experience is super high, like we've had a guy that came in just recently, and Bell knows Chad. He was lost his function, and he's got a herniated disc right now. And so the doctor did recommend, why don't we get you in for an injection to see if we can modulate your pain. And in his case, if the pain is like 9 or 10 and you can't sleep, then at that point, yes, it is worth an interventional technique to kind of see if we can't sort of knock the pain down and give him a bit of relief. But yeah, you're right. Generally, the old school of thought was that 3 injections is the most you should do in that body part. But that has changed too. And I think that's changed because they've changed the chemistry. But I can't comment on that because I'm not an interventional radiologist. But I do think the chemicals they used years ago are probably different than what they're injecting today. And so that's my rule. Kind of when people ask me, I said I wouldn't do more than 3, but I have had patients that have had several, and some people respond well to it and some don't. The majority may get, like, it's 50-50 from my experience from patients in the clinic. Some will say, wow, that gave me great relief, and others will say, I don't think it made any difference on the pain side. Blair still feels sore, but they might find that they get better range of motion. Where we're finding where it can be useful is for people that plateau with a frozen shoulder, because they do the injection deep into the capsule, and we find that those people, it causes a chemical reaction in the shoulder, and we can actually stretch them a little bit and push their range of motion a bit further. So the cortisone does have benefits in some cases, but certainly if you've tried and the second one didn't go as well, then I'd probably recommend, coming into the clinic, doing a full thorough assessment, and really kind of doing what I call a deep dive into your shoulder and figuring out what's the root cause of your shoulder pain. Why is that shoulder pain not going away? And then start peeling back the modifiable risk factors like we did when Arlene came in after her bad shoulder injury. And we just slowly built Arlene's function back up to the point where she had really good range of motion, and then went back to her normal active lifestyle.
Okay.
And so
you know where to start? Like, do I need another ultrasound first? Or is it always going to be bursitis is going to be the diagnosis?
So in your case, yes, you can see your family doctor if you want to do an ultrasound, because the ultrasounds are very, like I was saying before, the technology on ultrasound has really ramped up the last 10 years. So if you wanted to do that before you started physio, you could certainly do that. We find quite often people will come to us first, we'll do the assessment, we'll get going on some rehab. If people don't sort of feel better within a couple weeks, 2 to 3 weeks, and we can sort of gauge that by judging by how they're doing with their rehab as well, then we often will encourage the family doctor to send them for an ultrasound just to see, okay, like what's going on here? Why hasn't this pain started to resolve? And what we often pick up is some small subtle rotator cuff tears within the rotator cuff complex that we might not have seen clinically. We thought clinically it presented like a possible tear, but that just kind of validates, but it also gives us an idea of kind of where you're at and in regards to prognosis, like how long this might take to kind of calm down. And I think that's really important to kind of give people a timeline and give people hope that there is a result, but it might take a little bit longer if you've got that cuff tear than if you don't have a cuff tear.
Like I have full range of motion and I can do everything. I just always have pain. So
yeah. So it's kind of a chronic pain, good function sort of scenario. So that's a scenario that we see a lot in our clinic when people are just frustrated because they feel like, what's wrong? Like I've got good range, and we test their strength. So that's one where for me it sounds kind of gray, like I need to make more black and white out of that situation. And looking at you might be the best bet, or one of my colleagues to sort of sort you out and get you started back on a rehab program. The other thing is, as Marlene, I know you're active and you love to bike and skateboard and things like that. It might be something that you're doing in your exercise program that this might be kind of compounding or re-aggravating some of those symptoms. And we often like to ask people to kind of, bring in your exercise program. And in some cases they say, well, I used to do a lot of exercise with my shoulders, but I stopped because I got so frustrated, So it might be us kind of getting you back on a bit of a rehab or sort of fitness routine for your shoulders to kind of calm things down.
Okay, cool. Yeah, I'll come in and you can check me out.
Yeah, that'd be great, Marlene. It'd be good to see you again. So I treated Marlene for, was it an ankle or foot injury, I think?
Broken foot.
Broken foot. Yeah, that's right. Yeah. So I remember it now. Yeah. Yeah, so good. Well, we fixed your wheel. Maybe sorry, go ahead.
I said, thanks a lot. That's awesome.
Yeah, you're very welcome. My pleasure. Okay, good. Well, if that's it for tonight, then I'll sign off. And that was a really informative kind of 1 hour and lots of great questions. And so again, just if you have some help or if you have any questions, don't be afraid to follow up with Belle. And then Belle, if you want any sort of further information or that stretching sheet from Belle, just give her a shout or email her, and then she can send that out to you guys. But look forward to maybe seeing some of you next month. So next month, we're talking about knee pain. And we usually do our monthly webinars on the third Wednesday evening of the month, typically, unless there's a long weekend. So we do have some long weekends that tend to bump those like we had this month. So if there's a long weekend on the third weekend, we usually will bump it to the fourth weekend or fourth Tuesday of the month. But yeah, so I'll just kind of leave you guys with that. And again, there's our phone number and our website if you want to dig into it further. And I just wish you guys a great night, and hopefully we'll have a nice warm summer that we can all be active in. And please stay safe and make sure you're maintaining your social distancing, masking up when you're in close proximity of people, and certainly sanitizing your hands, and just be really careful because we don't want to lose anybody. All right, take care. Good night.